I'm your host, Dr. Warren Seigel, and welcome to 26 Minutes with Dr. Seigel on the Zurmed Show. On the show, we will feature local physicians and healthcare leaders who are experts in their respective fields and who will share their experiences and their wisdom. We will cover a broad range of health-related topics on the show, and today we have Dr. Mark Sonnenschine of South Brooklyn Health. Thank you so much for coming, Dr. Sonnenschine.
You're welcome. Thank you for having me here today.
So tell us a little bit about yourself. Where are you from?
So I'm originally from Staten Island, born and raised there. Now currently in Brooklyn with the family.
And what do you do?
So I'm a board certified hematology oncology working here at South Brooklyn Hospital.
So how did you go from Staten Island to becoming a board certified hematologist oncologist?
Many years of training.
What was that road like?
So went to undergrad in Towson State University. From there went to New York College of Osteopathic Medicine. And after that, I went and trained in Maimonides for both internship and fellowship.
And how long have you been here at South Brooklyn Health?
Started here in 2014, so about 9 years.
Oh, that's wonderful. So tell me a little bit about what you do. So you said you're an oncologist. Tell me about that.
So we treat both blood and solid tumors. When we say solid tumors, lung cancer, breast cancer, and blood cancers. So we look at simple benign hematology. So we look at anemias, low platelet counts, low hemoglobin, and we look at solid tumors, giving treatment with chemotherapies, making a diagnosis, helping the pathologists come up with it, the surgeons and pathologists get a diagnosis, and then proper treatment for the patient based on current treatment standards.
So oncology is the treatment of various types of cancers. And when we talk about blood cancers, I don't think people talk about that. I think most people know about prostate cancer, breast cancer, lung cancer. What is blood cancer?
Correct. So most people think of cancer, like you said, as solid tumors. Blood cancer is where you have an elevation and overtaking of the blood of an improper blood cell in the bone marrow, and therefore you come up with, there's some chronic ones and there's some acute ones. So leukemia, which is one type of cancer, lymphomas, which is another different type of blood cancer, and then multiple myeloma, which is a third type of blood cancer. So even though we classify, people don't think of it as a cancer, but they all are cancers.
So they're all different types of cancer, all within the blood system itself.
Correct.
So what are some of the signs or the symptoms that somebody would have to worry about?
So most people, when they have blood cancer, they may start, depending on what the different type of cell it is, they may have different problems. So if it's mostly like low platelets, they'll start having bruising, they'll start having bleeding. Low immune system, so they'll start having fevers, they'll have recurrent infections, they may be more tired, more fatigued than usual. They may be having some swollen lymph nodes, they start having swelling in their neck or under the arms. They may be having night sweats, they're just waking up with drenching sweats, not just regular sweat when you wake up with non-air conditioned room, but drenching night sweats. Unexplained weight loss, not dieting, but yet they're losing weight and something else is going on.
Wow, that seems like a lot of signs, a lot of symptoms, a lot of things to worry about. What would your advice be if somebody is really concerned about this?
So if someone is concerned that they have any of the symptoms, the answer is usually, if we're dealing with blood cancers, usually just a simple CBC may be able to help us determine if there's something abnormal. If it's just lymphoma where they have multiple lymph nodes, then they may need further imaging. But I think if they do feel it, they should seek the care of a professional to be able to make that diagnosis.
So when you talk about a CBC, you're talking about a blood test.
Correct.
And is that the kind of blood test that every primary care doctor would be able to do?
Correct. So that's just a standard blood test. Everyone does it usually routinely. Everyone's getting anyways routine labs at least once or twice a year during your regular routine physical. If there's an abnormality compared to last year to this year, the doctor may trigger some other need for other testing, and then that will warrant other testing and further workup, maybe seeking the help of a professional, of more specialists.
So assuming somebody's healthy and isn't experiencing any of those signs or symptoms that you talked about, are there certain risk factors that people should be aware of to say, hey, you are at risk for developing a blood cancer?
So most people, there are no true risk factors per se, besides someone who has a family history. So someone who has multiple other family members or other family that have, let's say, lymphoma or leukemia, are also at increased risk. Some people, if they're exposed to radiation, so after the Chernobyl disaster, things, high dose radiation, they could have it. Some people after chemotherapy, they got treatment for one cancer. Now, unfortunately, they could have a secondary malignancy of blood cancer.
So, I don't know of anybody who doesn't have cancer in their family. Should everybody be running to the oncologist because of their family history?
No. So for blood cancers, usually not. Many of them are sporadic. But if you do have a strong family history and you're worried, like I said, doing just proper regular routine screening by your primary care will help alleviate and catch it early if it does cause any problems.
We often talk about, when people say, what should you do to be healthy? We talk about eating right, whatever right means, exercising regularly, sleeping. Are there things that people can do to decrease their likelihood of developing a blood cancer?
Stop smoking.
Stop smoking.
Right. So we know smoking does have a part in it. Healthy lifestyle can do it. Obesity can have also increased risk of blood cancers. And then also, unfortunately, as people get older and the bone marrow is more affected, so old age can also play a part.
So I get really concerned when I ask this question. What do you mean by old age? The older I get, the more concerned I am about asking that question. So what age is old age?
So officially we say over the age of 65 is old age. But you do have some of the malignancies that are seen in younger ages. So you can see in a lot of pediatrics may have blood cancers. It probably is the most common cancer in pediatrics, more so than other malignancies. Usually chronic or indolent, slow-growing tumors of lymphomas or chronic leukemias that don't actually require any treatment, but will just be under observation.
So that's interesting. So just because you have a type of cancer, in this case a blood cancer, doesn't necessarily mean that you have to be treated?
Correct. Many of the slower-growing tumors we actually don't treat. We'll just continue watching every 3 to 6 months, have patients come in, do the workup, make sure that there's no significant changes, and when there's changes, that's when we would have to try.
Okay, so let me see if I get this right. I have to eat right, I have to not smoke, I need to exercise, I need to sleep right or enough,
Right.
I need to go to my primary care doctor who would do this blood work, and that will tell you whether I need to see an oncologist. But even if I have a diagnosis or a concern, I can go to an oncologist who might make a diagnosis of cancer, but I might not even need to be treated.
Correct.
Wow, that's incredible. That's incredible news. Is there a cure?
So some things have cures. Lymphomas, we do have cure rates. Leukemias, we see significant cure rates. Multiple myeloma, less likely. We look more for treatment related. But even the patients they're all treatable either way.
So they're treatable the way diabetes is treatable and asthma is treatable. I mean, people can live a long, healthy life and still be treated even with the diagnosis of cancer.
Yes, many times, yes.
Wow, that's incredible. I remember as a kid when I was a child, we didn't even use the word. I remember, people saying they've got the C
word.
We've come a long way. So these are curable diseases, and if not cured, they're diseases that you can live with. What makes somebody die from cancer, and what makes somebody cured from cancer? Do we know?
So I don't think we know fully. We know that there's lots of genetic factors, not hereditary genetic, but within the actual tumor, when we look at the genetics of the tumor, we are finding more and more ways to treat, and we're able to prognosticate based on those markers, we'll say. But like I said, there's always treatment, and most of the patients will, I would say, at least 60% will go into some form of remission or cure rate, if not more.
So when you say remission or cure rate, are we talking about 1 month, 6 months, 5 years, 10 years? What are we really talking about?
So you're looking, when we talk about 5 years, we basically talk about a 5-year overall survival. So you're having somewhere in the vicinity between all the blood cancers, I would say somewhere between 60 to 75%, depending on what type it is.
No, that's got to take a lot of work. It sounds like it's going to be more than just the oncologist. Who else do you work with to support people who are dealing with this? It sounds like something that you need more than just one person to help.
Right. So in our system, we'll have social workers try to help out. We have nurses to ensure that patients are compliant with their medications. If it's IV chemotherapy, they're coming in for the infusion center. If it's oral chemotherapy, we have nurses contacting them, making sure the compliance is there, plus any side effects are properly dealt with. We have PAs and NPs on our team to help out, again, getting the medications and making sure the patient's staying healthy and able to tolerate all their treatment.
So PAs are physician assistants and NPs are nurse practitioners.
Correct.
So it's not just a physician model. You're dealing with physician assistants, nurse practitioners. You mentioned social workers. I assume the social workers are helping with emotional support?
So both emotional support, unfortunately many of these patients, sometimes you'll have family issues, the patient's at home, family can't properly care for them, so we need to get proper help in there to help out the patients. Sometimes it's costly drugs, so we're getting foundations to help out with copay assistance. So it's more than just the physician directive just giving it. There's also, we have the pharmacist staff, we have the sometimes radiation staff. So
sounds like a huge team that's responsible for that kind of survival rate. Are cancer rates going up? It seems to me that I hear a lot more about people with cancer today than years ago, but part of it could be that we're talking about it more. Are the rates going up, or has it always been?
Part of it is I think
common?
we're talking about it more, plus we've gotten more advanced in knowledge and detecting it better, so we're asking for more screening, mammograms, colonoscopies, PSAs, which are simple blood tests for prostate cancer. So we're diagnosing them earlier also. So I think we're seeing a lot of earlier stage more than late stage cancers.
It's interesting. I had a conversation with a friend and I said something like, gee, you never heard so many people having that disease. And he quickly said, that's because they all died when they were 45 of pneumonia.
Correct.
But now we have the pneumonia vaccine, so people are living longer. So I guess the fact that more people may be developing cancer is actually a good thing because they're living longer. But it sounds like you guys and gals are doing a really great job helping all of us live longer, even if we have a horrible diagnosis. You mentioned oral chemotherapy. Those are, I assume those are pills that you take at home.
Correct.
So does it mean that you're going to be in the hospital?
So, right. Pills you take either daily or based on what the regimen is, or which you're self-controlling. So you're getting it from the pharmacist, you're taking it at home, minimal side effects, and people tolerate it, well based on what the drug is.
Mm. When I think of chemotherapy, the first thing I always think about is my hair's going to fall out, I'm going to be losing a lot of weight, I'm going to be bedridden, I'm going to be miserable. Is that true anymore?
Not anymore. So that used to be the chemotherapy was given in a hospital-based setting, everyone was vomiting, throwing up. Nowadays, it's given outpatient. You come in, a couple of hours, they go home, the patients. Because of the fact that we have so many good drugs to prevent the nausea, we know how to treat most of them. We know the drugs, their side effects, and what we can predict. We're able to treat, I would say, most of the tumors, most of cancer as an outpatient setting.
Wow, you make it sound like so easy, but I'm sure it's anything but easy. But I guess the old adage of practice makes perfect. If this is what you do, you get good at it. Is really true.
It's true. It's also a constantly changing world because we're seeing all these new drugs continuously come out, which is great for the patients because we have many more options available to treat them. But it's also, we got to stay up on top of the curve and keep learning and changing.
That's the beauty of medicine, is, what I learned 5 years ago is out, and we now know a lot more than we did. One thing that I've heard a lot about, maybe you can speak about, is bone marrow transplants. For a while, it sounded like bone marrow transplants were going to cure everything in the world. Where are we with that? And is that something that you use with blood cancers?
So we do use it frequently. With newer medications, we're using it less frequently, I would say. We have something called CAR T cells, which seem to be more beneficial up front rather than after transplant. But we still do. We don't do it here at South Brooklyn Health. We send the patients to a city, most of them are the city that have the transplant centers. So they have a team of doctors who are usually, again, oncologists that are specialized in bone marrow transplant, and they'll determine the proper timing for it. Usually you have to give high doses of chemotherapy to knock out the bone marrow, and then you can go ahead and give a bone marrow transplant.
Now you mentioned CAR T cells. What is that?
So that's basically stimulating the own body so they're taking out the T cells. They're actually in the lab targeting directly against the person's tumor and then giving it back to the patient. So they're stimulating their own T cells to go ahead and hit the target.
Wow, this almost sounds like science fiction. So it's the body's own immune system with the help of the people in the lab to be able to actually fight your own cancer.
Correct.
Wow, incredible. And what's a success with that?
Actually, very well. They're doing well. We don't do it here, mostly done in transplant centers. But we went from one drug to I think 3 or 4 on the market already, if not more. And the success rate in the proper setting is actually quite high.
Wow. So you said you've been doing this for a number of years, and you clearly are very knowledgeable about it. And how did you get involved with oncology? What brought you to this field?
When I was a resident, I guess dealing with patients, and I felt that it's more of a chronic condition nowadays, and you're really there helping them during. It's a trying time when someone's diagnosed with cancer. The first thing is I'm dying, and then you start explaining that no, you're going to live, we're going to treat, and it's no different than high blood pressure or some coronary disease. The same thing. We turned it into a chronic field now.
Wow. I'm sure that took a lot of time, a lot of hard work. But what attracted you specifically to this area?
So I think the relationship you develop with your patient is more so because, again, they're relying on you and you're relying on them to be compliant, but they're relying on you to really help them out during this time. And the changing world. I mean, when I started, we didn't have most of these drugs out there, and now it's constantly changing, which gives us, hope in the setting of a malignancy.
Wonderful. I always say in most fields of medicine, and I'm sure in oncology it's no different, you have more than one patient. You've got the whole family. How do you support the family through this? I know it's got to be hard enough to take care of the patient, that he or she is struggling, but how do you support the family around them?
So I'm a believer honesty is the way to go. So you have to explain to the family what's going on. You have to help kind of predict for them what's going to happen after treatment, before treatment, how you do it, and explain to them that the patient needs their help to get through this, and include them in decision making and treatment planning. Therefore, they feel more involved and they help out.
It's got to be also a very depressing time. There's got to be times when people just want to give up. And I always worry about those people who don't have the supports because they don't have a family or they're not connected to other people. How do you deal with those situations? Those got to be particularly hard.
So those are more difficult. You'll try to bring them in more frequently, so at least you have they have you as your support. Again, you'll try to reach out to a social worker, case manager, see what support you can get at home. Can you get some, there are oncology foundations that would send someone in to help the patient out. And you gotta keep the patient involved and make sure that all their symptoms are well controlled, so therefore they're not really becoming depressed and want to give up early.
Wow. It sounds like they almost become part of your family.
Yes.
Yeah.
you become family.
Yeah, that's got to take a toll on you. How do you and the team deal with that? And I hate to ask, but how do you deal with the loss when you're not successful?
So everyone deals with it a little differently. It is hard when you lose a patient because you question yourself, did I do the right thing? Did I give the right treatment? Should I push something more or not? Especially when you've been treating a patient for many years, it's even harder because you became really close to the patient. But we have to realize that we're human, we can only help out up to a certain point. As you know, with the bad disease, sometimes we're able to get them to that point. And we look back and say, well, you know, how good were we with, you know, the patient got a bad diagnosis 5 years ago, look what they did in 5 years, what they accomplished. And you try to not bring it home with you, right? It's at the door, you kind of forget, walk into your house, enjoy your family, even though you get phone calls and everything else.
I'm sure that's easier said than done. I can't imagine a more difficult time. You're there for the patient on the best days and the worst days, and I'm sure you love to remember the best days, but and would love to forget the worst days. So this show is about staying healthy, and you mentioned don't smoke. You mentioned keeping your weight normal. You mentioned eating right, sleeping, seeing your primary care doctor, making sure you get those blood tests. If there's a problem, don't ignore it. Get that blood test to make sure that there isn't something going. Are there other things that you'd like to tell people to do to take care of yourself besides stay away from Chernobyl, which I definitely don't think we should be getting radiation? Are there other things that you would suggest to our viewing audience to stay as healthy as possible?
I think you covered it. I mean, healthy diet, exercise, don't smoke, no alcohol.
And the one thing we can't change is our family history.
Correct.
Right? So something else to blame your family for and go into therapy, right?
Well, I think it's important to know your family history. So therefore, that would help out also because it helps your primary care know what testing needs to be done, what's proper screening for you. Because if someone has a family history of X, they may need this testing. Someone has a different one, they need other testing. So it is important. Unfortunately, sometimes people are adopted, patients that are adopted, we don't know their history at all. So we'll do all the standard screening, but it's difficult to know if he's at risk of other diseases more higher than the regular population.
You know, that's a very good point. I talked earlier about the stigma of cancer, and so many people don't talk about the grandparents died of this, or aunts or uncles. You know, it's you know, no different than the stigma of mental illness for so many people. People don't want to talk about it, but that's a wonderful point.
That's true.
Even our kids, I often think, don't really know what's going on as much as we need them to know,
right,
for their own future. How can healthy people help those who are struggling with cancers, particularly blood cancer?
Right. So I mean, in blood, number one, obviously, you want to help out. If you have a relative that's sick, you'd want to reach out and try to support. There are foundations that help get involved. And then as blood cancers, so we know that, like we discussed, bone marrow transplant. So if someone is diagnosed with blood cancer and they're deemed so a candidate for bone marrow transplant, they'll reach out to the relatives first. If the relatives are able to be a match, great. If not, then they go to a foundation. So there is the National Bone Marrow Registry, which is no simpler than having a swab nowadays from the mouth. And you could be registered in the system that if someone out there is a match to you, they would call you up, you'd get a little further testing to see if you're really a match, and then you'd be able to offer a bone marrow transplant.
Wait a minute, let me get this right. So if I want to be a bone marrow donor, I just have a swab in my mouth. They don't have to put a needle in my bone?
Later on, not in your bone. Later on, they'll do more blood work.
Okay.
But yes, but initially, just to register yourself, it's just a simple swab for your DNA, and they're able to determine that what your basic level is, and then later on they'll need more specifics, but not to be in the match.
So I can then decide at some future time if I want to donate bone marrow. It's not a foregone conclusion that once I sign up, I have to do it.
That is correct.
Wow, that's really wonderful, wonderful information. And it's something that we can actually do to help others. The other thing that I really wanted to ask you about is blood donation. Is that something that oncologists need? Do you need to get the word out that more people need to donate blood
Definitely.
to help your patients?
Definitely, because many of these patients with blood cancers, while you're giving them treatments, their counts will drop and they will require transfusions. So we have to go to the blood bank to go get that. So we encourage people to go out and donate blood, donate platelets. It's not a difficult procedure. Yes, you're getting stuck. You're having, to be having blood donation, but you see blood drives all over the place. If you're healthy and you're young, you should definitely be donating.
Great. In addition, National Marrow Donor Program. That's how we can all support each other.
Correct.
Thank you so much for some wonderful information, and thank you for what you do every single day.
Thank you.
And thank you for your interest in our show and your desire to become involved and educated. I invite you to visit our website at www.zurmed, that's ZURMED.com, and check out our tools and connect with us on social media. You can also call us at 718-510-2103. For now, please stay well, be safe, and thank you for tuning in. Goodbye.